Hello friends, let's discuss the anesthesia questions that came in INICET, and you know it was a little surprising kind of a decision at the last moment to give two sets of papers. So we were expecting around 2 to 3 questions in every set. We got overall 5 questions. It was difficult for us to understand which session because there was a little bit of blurring based on the feedback, the recall given by the students. So I've compiled all of them together. Doesn't matter whether it is first or second. What matters is an anesthesia question, and this time anesthesia questions were a little tricky. I won't say very tough because everything came from the part that we normally discuss. But yes, I will definitely say they were little different from the routine things that we expect and want from a question in anesthesia. I have always maintained this fact in front of you that CPR as a topic is a 20-minute topic that will give you one short question in the exam. So you got one question, but again I told you it's a little tricky question. People could not recall the options that were supposed to be marked, but they could recall the question. The question was arranging the steps of CPR, and the options that they gave was check pulse, respiration, responsiveness, compressions, and bag and mask. And then you have to choose a combination of which would be the right order. So now let's discuss the chain of survival in a cardiac arrest situation, which is outside hospital cardiac arrest. And these are the broad set of guidelines that we follow in an event of cardiac arrest, right? If you look at it, the first step is activation of ERS, emergency response system, that is dialing 911, or if you are in India then 108, followed by high quality CPR, followed by defibrillation, followed by advanced resuscitation, then post cardiac arrest care, and then recovery. These are a broad set of guidelines. But when you actually receive the patient, you always go from BLS, which is a basic life support, to ACLS, which is an advanced life support. And BLS is where you recognize the cardiac event. So recognition happens in BLS, and it has a proper step-by-step process. So first step in any event, doesn't even matter whether it is cardiac arrest or not, is to always verify the scene safety. This is done so that the rescuer doesn't become the victim. You know this very well. Then the next step is always to check for responsiveness. Now this is very logical. You can't go on and start doing CPR on someone who is not in cardiac arrest. CPR is meant for cardiac arrest. Cardiac arrest is when your heart stops beating. So unless and until you have diagnosed cardiac arrest, you should not start CPR. CPR means chest compression and breathing. But you always need help. So what they have done is, first you take care of yourself. So first is to verify the scene safety. Second step is to check for responsiveness. There will be two outcomes. Either the patient is unresponsive or the patient is responsive. If the patient is responsive, that means it is anything but cardiac arrest. So you will see what you have to do. But if the patient is unresponsive, then you need to call for help. Because unresponsive patient can mean lot of things, and the most dreaded thing of that is cardiac arrest, and you want help. So you will dial 911 or 108, tell them it's an event of cardiac arrest, please send an ACLS team with AED. So you would be very specific in what you tell them, and then you go on to check for pulse and breathing, which has to be done simultaneously, not more than 10 seconds. If you do not get pulse and breathing, then you consider it as a cardiac arrest, and then you start your CPR. CPR is always CAB, so you follow it by chest compressions, airway, and breathing. So you start in BLS with chest compressions of 30:2. That is 30 compressions followed by 2 breaths. That can be mouth to mouth or mouth to mask or bag and mask. Anything what is available to you, right? So now look at the options in the question. Are the 5 things in the things that we do? So yes, you check pulse, you check respiration, you check responsiveness, you check do chest compression, start bag and mask. Now what did I tell you? What is the first step? Always check for responsiveness. When there is no responsiveness, then you activate ERS, call for help, and then move on to next step, that is checking for pulse and respiration. That has to be done simultaneously, not more than 10 seconds. If you do not find any pulse, or you get a agonal gasp or a gasping breath or no breath, then you will immediately start chest compression and then 30:2, so bag and mask ventilation. Now, I don't know what options were given, but I'm pretty sure one of the option would be fitting right in it, where there would be either pulse first, respiration first, or vice versa, but there will be only one option where all the things will fall in place. Now, there will be common confusion that will come out of it, sir, that all the guidelines say check for pulse and respiration, then how can we differentiate? So it is very logical that there will be only one option in which rest of the things will be in the right order. So we don't know why they have given it as separate options, because all the guidelines, they say check pulse and respiration simultaneously, not more than 10 seconds, right? So if the guidelines say you have to do it simultaneously, that means you have to do simultaneously. Doesn't mean we can't mark the question that has come here correctly. Why? Because we know there will be only one option of the 4 where rest of the things will be in the same order, the correct order. So you just try to find which option has all the other things in the correct order, and whatever it is given, maybe it was respiration first, pulse then, or pulse then respiration, whatever it is. I don't know, because these options have not been recalled by students correctly. So I'm not aware of what happens, right? So you will start CPR, you will immediately check for responsiveness, then you will check for pulse and breathing, then you will do chest compression followed by bag and mask ventilation. So this was the first question that came in INICET. Second, it's a very predictable question from the perspective of what is taught to you in respiratory medicine, a very common topic of ARDS. Everything was given to you. Actually, a very good question. 60 kg on ventilator with 5 PEEP, 360 tidal volume, inspiratory expiratory ratio 1:2, pH 7.38, PaO2 50, PCO2 35, FiO2 90. What is the next step you do? So if you look at this question, then you would not find any abnormality in this patient, because the ABG is spot on, the ventilatory settings are spot on. Then what is the problem? The problem is that we are using very high concentration of oxygen. You're not supposed to use very high concentrations of oxygen, which can be toxic. At the same time, you are getting a low normal level of PaO2. Now, normal expected PaO2 in a patient of ARDS is between 60 to 100 mmHg. So yes, 50 is hypoxia, right? So you need to work on it. So let's see other parameters. What is the pH? pH is 7.38, which is again normal. PCO2 is 35, which is again normal. Tidal volume is 6 ml per kg, which is again something you want. PEEP 5, okay, that is physiological PEEP. Inspiratory expiratory 1:2, which is again normal. So everything is normal, and yet you are getting some hypoxia. So hypoxia in the setting of ARDS, that means it is not proper oxygenation. What would you want to do? You would want to increase the PEEP. When PEEP increases, it causes alveolar recruitment. And alveolar recruitment will improve oxygenation. And improved oxygenation will increase the PaO2 and thereby help you decrease FiO2. As the oxygenation will start to increase, you can start coming down on the fraction of inspired air that is containing oxygenation, right? So you can increase the respiratory rate, you can change the inspiratory expiratory ratio, that is all fine. But the first thing that you do is you can increase the PEEP. You can increase the PEEP till 15 to 20 centimeters of water, looking at the hemodynamics of the patient. And that level of PEEP is also acceptable, right? So the next best option here would be to increase the PEEP. If you increase the tidal volume, it will cause more barotrauma. You actually do not want to increase the FiO2 more, because 100% oxygen is very toxic. And yes, you can make inspiratory expiratory ratio 1:3. If you increase it 1:4, 1:5, that is also, you are actually trying to recruit the alveoli, but the first thing that you would do is to increase the PEEP. Increase the PEEP, right? You can't increase inspiratory expiratory ratio, because in the patients of ARDS, you actually want to do inverse ratio ventilation, where you want to increase the inspiratory time. So you can make it probably 2:1 or 3:1 rather than 1:3. Okay. Now this was a new interesting question which could have been solved simply by knowing the anatomy. I won't say it's very easy, but at the same time, it is something of a logic based question. So let's look at what they have asked. Local anesthetic injected below inguinal ligament during femoral artery catheterization, which nerve will be blocked? Now, we know the basic anatomy in the inguinal region is from medial to lateral. We have vein, artery and nerve. This is something you all know very well. You are wanting to cannulate the femoral artery, so you will give local anesthesia around it. When you give local anesthesia around it, you are bound to block the femoral nerve. So the question was, what is being blocked? So the correct answer, femoral nerve. What is not blocked? Genitofemoral is not blocked, lateral cutaneous nerve of thigh, obturator, because they are all coming from up. They are all a part of the femoral nerve, but they all come from above the inguinal ligament and they have already bifurcated from the lumbar plexus, right? So if you are doing, say, a fascia iliaca plane block, maybe then you can spill over the entire local anesthetic volume and block these nerves. But I'm just depicting it here that when you block a femoral nerve, you block anterior femoral cutaneous nerves, which is here in this region, infrapatellar branch of saphenous nerve, which is here, and saphenous nerve, which is here. So it gives you exactly the area where you are wanting to do the cannulation. But you don't really block the genital branch of genitofemoral nerve, which has been asked in the option, because that will, the nerve will come from above. All right. So if you are going suprainguinal, then you might be able to block the iliohypogastric nerve and ilioinguinal nerve, which also supply more or less the area around it. But then that is not something that you block when you are blocking local anesthetic below inguinal ligament. So the correct answer to this question would be femoral nerve. Expected question from notes. I don't think there should have been any doubt in this question. RSI, all are true except method of choice for cardiac arrest, high volume, low pressure, induction, muscle relaxant given simultaneously, pre-oxygenation. Let's first discuss RSI. RSI is rapid sequence induction or intubation. We know we do it in patients with increased risk of aspiration as a modification of our technique to decrease the risk of aspiration. Am I right? Am I right? Yes, I am right. So how we do that? By 4 P's of RSI. Basically, you're wanting to decrease the time interval between induction and intubation so that you decrease the risk of aspiration. So we do it in 4 steps. The first step is pre-oxygenation with 100% oxygen, which increases safe apnea time and thereby the chances of hypoxia become lesser. Second is paralysis. This is the step which is very critical. You administer standard induction dose of the induction agent. Usually in traditional RSI, it is thiopentone 200 milligram and muscle relaxant scoline 100 milligram simultaneously without interposed bag and mask ventilation. You don't do any bag and mask ventilation in between. Finally, there is protection where you apply cricoid pressure or Sellick's maneuver. That is, you press the cricoid cartilage down to block the upper end of esophagus. This decreases the risk of aspiration. And finally, you will secure the tube with a cuffed endotracheal tube, right? So now look at the options in RSI. All are true except, will you use a high volume, low pressure cuff? These are the standard cuffs that we use. I have told you this thing before also, that the standard cuffs that we use are all high pressure, low volume cuff. We don't really high volume, low pressure cuff. We don't really get any high pressure cuffs in the market because they were very morbid. So will you do this? Yes, you will do this. Induction muscle relaxation given simultaneously? Yes. Pre-oxygenation? Yes. So by exclusion only, the answer would be method of choice cardiac arrest patient. But still many students later on told me that, sir, we have marked option A. Now you only tell me that in cardiac arrest patient, is aspiration a concern for you? Somebody has died. When you say cardiac arrest, the patient has died. Is aspiration your primary concern? No. Your primary concern is CPR. And for CPR, you need to do air compression, airway breathing. Even if you don't secure the airway, it is fine. Just give mouth-to-mouth respiration. Even if there is aspiration, that is fine. If you revive the heart, we can treat aspiration later. But what is the point of saving the patient from aspiration but don't really doing a good CPR, right? So no, this is not a method of choice in cardiac arrest patient, because in cardiac arrest patients, our idea is not to prevent aspiration, but our whole focus is to restart the heart. This is actually a very old AIIMS question that has been repeated, very old. And one of the options that time also was that it is preferred in cardiac arrest patients. So they have simply taken a very old question and they have formulated it in a better language this time, right? Coming to the last question, and again this is something that will be taught to you in pediatrics as well, because we deal with pediatric patients, so I am teaching you here, it will be taught there also. IV cannula in newborn, which of the following is correct? Again option and then option based question. Options were 22G cannula, 24G adhesive patch, normal saline 5 ml syringe. And if you have been to any NICU facility or you have been to OT, you know how to take a pediatric IV line. You always take an IV line, then you try to anesthetize the area for the kid by using an EMLA cream. That is a local anesthesia. Then you apply chlorhexidine as a antiseptic. Then you identify the vein and you insert the cannula. But sometimes in neonates, because the blood, the vein is very small, the blood flow doesn't come back for you to know whether in the right place. So you take a 5 ml syringe, you put normal saline in it, you flush the cannula only when there is no visible swelling and the the normal saline is going, then you put the adhesive patch. So what you don't do is, you don't use a 22G cannula in a newborn. It is always 25 or 24G, mostly 24G, which is a yellow cannula. So the correct answer to this question is B, C, D, E. B, C, D and E, right? So this is what the recall I have got. This looks more credible, that you use a 24G cannula, adhesive patch, you normal saline 5 ml syringe. Now what I have given is, I have given you the photograph of these cannula which you have seen many times, and I have given you the color coding. Along with that I have given you the average flow rates. Now these flow rates might change from author to author, from article to article, from source to source, because it depends on the length. If you have a longer length, the flow rate already of course decreases. If you have a shorter length, it increases. And so the standards are not really uniform all across the world. So whichever author you're saying, so you get a rough idea that for a 24 gauge it is around 10, then 30 for a 22 gauge, then 60 for a 20 gauge, 100 for a 18 gauge, then 230 for a 16 gauge and 270 for a 14 gauge. So this is the rough idea. If you keep this rough idea in mind, then whatever values come in the exam, you can try and correlate and find the best match. So these were the 5 questions in INICET in anesthesia that you got. Everything came from what you have studied, what is there. It's just that sometimes things don't appear that direct as we expect them to be. This is a lesson for you for your NEET exam, that yes, you will get a lot of questions in the exam from your notes, but they might not be always in the same language or the form, but their application will be the same. So trust your notes. Go back to your notes, start flipping them, start revising them, and wait for DVT. We are here to give you a grand event that will include all these most important things in a very compiled format, right? So all the very best. God bless you.